and this will be taken by Dr. Ghatdeep Kaur. She is Surgical Oncology Fellow in Max Hospital, Vaishali, Ghaziabad, and her mentors are Dr. Pawan Gupta. He is Senior Director at Max Hospital in Surgical Oncology. Dr. Akshat Malik. He is a Senior Surgical Oncologist in Max Saket. And Dr. Suman. He is a Senior Oncologist, Senior Surgical Oncologist at Max Vaishali. Dr. Ghatdeep, over to you.
Okay, ma'am. Good evening, everybody. I am Dr. Ghatdeep Lamba, and I'm a head and neck fellow at Max Vaishali. The topic of my discussion today is current role of surgery in management of oropharyngeal carcinoma. So, as per standard guidelines, the early lesions in oropharyngeal squamous cell carcinoma, they are managed with single modality treatment, either surgery or radiotherapy. The advanced lesions are treated with biomodality treatment, surgery with adjuvant radiotherapy or chemoradiotherapy. Salvage surgery is also done in recurrent cases. So oropharyngeal squamous cell carcinoma was traditionally treated with open surgeries due to limited access in this complex anatomical location. The invasiveness of open techniques caused severe functional morbidities, compromising speech and swallowing. Moreover, they required complex reconstruction. So clinical trials were conducted in late 1990s, which demonstrated chemoradiotherapy achieved locoregional control and survival outcomes comparable to the open surgery with less morbidity. So chemoradiotherapy began to replace the surgical techniques. However, it was associated with late onset toxicities such as trismus, ORN, xerostomia, dysphagia. So with the emergence of HPV, younger population became affected, which was highly educated. They were non-smokers and they had better prognosis. So quality of life again became an issue, and there was a search to de-intensify the treatment. The interest was renewed with the onset of minimal invasive surgeries like TORS and TLM. So now surgery is an option in early lesions as a single modality treatment, in advanced lesions as a biomodality treatment, and in salvage cases. So there is wide range of surgical techniques are available to manage oropharyngeal squamous cell carcinoma. These include open surgeries, which include mandibulotomy, pharyngotomy, which are used to treat advanced tumors, or in salvage surgeries, and transoral techniques. These include TORS, TLM, and classical transoral technique using monopolar cautery. So these are the various open surgical procedures which are used in oropharyngeal squamous cell carcinoma. These are quite morbid and they are obsolete now. The transoral, so let's discuss them one by one. So first is transoral transcervical pull-through procedure. This involves prolapsing the contents of the oral cavity and the oropharynx to the neck, releasing the oral cavity and the oropharyngeal attachments from the mandible. Others include transhyard pharyngotomy, lateral pharyngotomy, median mandibulotomy or Trottis procedure, lateral mandibulotomy, and mandibulectomy. So mandibulotomy. Mandibulotomy can be either median, paramedian, or lateral. Median mandibulotomy is done between two central incisors. Paramedian is done between the lateral incisor and the canine, and lateral mandibulotomy is done posterior to the mental foramen. Now, the median mandibulotomy can be straight or in a step ladder fashion. It is done in step ladder fashion for better stability. So the median mandibulotomy can also be combined with mandibular swing. In this, the mandible is retracted laterally, and better exposure is given. A better exposure is available to the entire tongue, to the tonsillar fossa, to the soft palate, to the RMT area. So in mandibulotomy, we dissect the floor of the mouth mucosa, the mylohyoid, and the digastric muscles. So these are the pictures showing mandibulotomy. So here we can see a median incision is being given median lip split incision is being given up to the hyoid bone. So the mandibular osteotomy is done using a saw after pre-drilling the mini plate screws. These, you can see these holes, they are pre-drilled for the screws later, to be put later on. So we divide the mylohyoid muscle and we retract the mandible laterally, and we see the tumor to be resected. So we give a transverse wedge resection is planned, and securing adequate margins in all 3 dimensions. So resection, it begins in the interior aspect followed by the posterior aspect. So the defect is closed with absorbable sutures. Closure of the floor of the mouth, it realigns the mandible, and mini plates are used to immobilize the osteotomy. Next comes the lateral pharyngotomy. So lateral pharyngotomy is done in tumors with poor transoral access. It can also be combined with oral approaches in tumors with significant inferior extension requiring flap reconstruction, and in cases where neck mobility does not allow flexion and adequate vision of the lesion. So in lateral pharyngotomy, what we do is we expose the carotid sheath and we retract it laterally. We identify the superior pole of the thyroid and its vasculature. So pharyngotomy location is then identified by placing an index finger along the base of the tongue inferior to the posterior tonsillar fossa. It is a blind technique. So here in this procedure, there are chances of injury to the hypoglossal nerve, to the superior laryngeal nerve, and to the lingual artery. Next is transhyoid pharyngotomy. So this is done in early stage cancers of the base of the tongue and oropharynx and posterior wall of the oropharynx, and can be used with without neck dissection for benign lesions or low grade cancers of the salivary gland origin. So in transhyoid pharyngotomy, we release the suprahyoid musculature from the hyoid bone. The hyoid bone can either done by transoral palpation, and the base of the tongue can be retracted anteriorly. So here you can see there is a lesion at the base of the tongue, and the base of the tongue has been retracted anteriorly. So advantage of this procedure is that we avoid the facial incision and mandibulotomy. Disadvantages include that there is a communication that is formed in the neck, and patient might have difficulty in swallowing. These techniques, these are obsolete now because better options they are available. So next comes the transoral procedures. Transoral procedures, these include TORS, TLM, and TAUS. TORS stands for transoral robotic surgery. TLM stands for transoral laser microsurgery, and TAUS stands for transoral ultrasonic scalpel surgery. So in these 3 procedures, the tool is different in all 3. In TORS, we use the robot. In TLM, we use laser, and in TAUS, we use ultrasonic harmonic scalpel. So these are the various surgical sites that can be accessed by transoral procedures. So what is the advantages of transoral procedures over the open surgeries? So open surgeries, they led to significant treatment-related morbidities, prolonged hospitalization, gave cosmetic deformity, and gastrostomy and tracheostomy tube dependence. Transoral surgeries, they had limited damage to the musculature, to the neurovascular structures and the normal tissues. There was reduced risk of fistula, abscess, and ORN in these cases. They had faster recoveries with shorter hospital stays and reduced morbidity. So how do we select a case for transoral resection? Rich et al. Identified 8 factors known as 8 T's, according to which we can select whether a case is fit for transoral resection or not. So first is the teeth. If there are large teeth, or then visualization can become an issue or it can be obscured. Similar is the case with trismus. Transverse dimension, tora in the mandible can also obscure the vision of the lesion. Tongue, if the patient has a macroglossia, then the retractor blades cannot be fit in properly. Tilt, if the patient has a cervical spine disease, then there can be difficulty in extension of the neck. Treatment, if the patient has gone any prior surgical and non-surgical treatment, so exposure can be limited in these cases. And tumor, if the tumor is friable, it is bulky, and we cannot get a good oncological margin, then it can be an issue. So Weinstein and his colleagues, they classified the contraindication for TORS into 4 categories. These included vascular contraindications, functional contraindications, oncological contraindications, and non-oncological contraindications. Vascular contraindications, these included a retropharyngeal carotid artery. If the tumor is in the midline, if the tumor is adjacent to the carotid bulb, if the tumor is encasing the carotid artery. Functional contraindications included tumor resections, more than 50% of the requiring more than 50% of the tongue base musculature, or more than 50% of the posterior pharyngeal wall, or tumor resection requiring up to 50% of the tongue base as well as the entire epiglottis. Oncological contraindications include all T4P tumors, or tumors that are tumor causing posterior lateral fixation of the cancers to the prevertebral fascia, unresectable neck disease, neoplastic related trismus, and multiple distance metastasis. So transoral robotic surgery. The transoral robotic surgery setup consists of 4 main components. First is the console, where the surgeon sits. It has a monitor and controls. So this is the console. Then there is a patient side surgical cart where there are 3 robotic arms. There is a central arm for endoscopic camera, and there are 2 lateral arms for the surgical instrument. So this is a patient side surgical cart. The assistant stands here near the patient side surgical cart. He does suction, evacuation, and also provides hemostasis if required. Then there is vision cart to provide view of the surgical field from the endoscope, and endowrist instruments for tissue dissection. So this is a picture showing TORS. Here you can see this is the first picture. It is showing carcinoma of the tonsil is there, and here we can see the incision is being made in the anterior tonsillar pillar. The incision is extended superiorly up to the mandibular tuberosity and inferiorly up to the posterior floor of the mouth mucosa. And here you can see that the tonsil is being separated from the superior constrictor muscle. And if the tonsil is mobile over the superior constrictor muscle, then we remove the tonsil and we excise the superior constrictor muscle separately. However, if the tonsil is adherent to the superior constrictor muscles, then the superior constrictor muscle, it forms the base of the our dissection and is resected along with the specimen. So next comes the transoral laser microsurgery. In transoral laser microsurgery, we use lasers, preferably carbon dioxide laser. So this is a TLM setup. So all laser safety precautions are taken, and intubation is done with a laser-proof endotracheal tube. So here we can see there is a microscope. There is a laryngoscope which is used for visualization. There is a micro manipulator which is like a joystick, and you can control the laser beam with it. This is a reflection mirror where the laser light gets reflected inside the laryngoscope to the tumor, and you can precisely cut the tumor accordingly. So next comes is transoral ultrasonic scalpel surgery, or TAUS. So this is alternative to TORS. It uses ultrasonic energy for cutting and coagulation, and it cuts and coagulates the tissues simultaneously, and there is low heat and lateral thermal energy dissipation in it. So lastly, in transoral resection, we have direct transoral resection. So small superficial well-circumscribed lesions of the tumors of tonsil can be removed with conventional methods like electrocautery. So TORS versus TLM. So TORS has a bit upper hand over the TLM, because TLM, it is laser which goes in a straight beam, whereas TORS, it can have a 3D panoramic vision and a 360-degree range of motion. It has better optics, and it filters the hand tremors, and there is an easier en bloc resection in TORS than TLM. So several good publications are there to prove that TORS has a good overall surgical outcome and local region control in oropharyngeal cancers. So to summarize, the early stage oropharyngeal squamous cell carcinoma should ideally be treated with single modality therapy, either primary surgery or radiotherapy. There are various studies which compare the efficacy between surgery and radiotherapy, and they found that there is an equivalent efficacy between the surgery and radiotherapy. A study was conducted by D. Almeida et al., which showed that TORS had a better 3-year overall survival and DSS rate than the definitive radiation. So advanced stage oropharyngeal squamous cell carcinoma, both chemoradiotherapy and surgery plus surgery with adjuvant radiotherapy with or without chemotherapy can be used in advanced cases. Open surgeries may be necessary if bone infiltration is detected. So Weinstein et al. Compared oncological and functional outcomes in patients undergoing TORS followed by adjuvant therapy for advanced oropharyngeal carcinoma and found disease control, survival, and safety commensurate with standard treatments and markedly lower gastrostomy rates. So next we come to the salvage surgery for oropharyngeal cancer. So in cases of recurrent cancer, re-radiation is limited and restricted to cases which cannot be surgically salvaged. And moreover, the outcome is better with recurrence more than 2 years of definitive treatment. Systemic chemotherapy is confined to patients with unresectable disease or distant metastasis. So open surgical resection is the standard of treatment in recurrent cases. The open surgery in previous irradiated fields, they can have high complication rates. TORS and TLM may provide a viable option to the open surgery in salvage settings. So there are some studies which have shown that the outcome of TORS in recurrent settings at 2 years is good. So we can discuss some of these studies. So White et al. They compared TORS with standard open surgical procedures in recurrent cases of the oropharynx, and they found that there is shorter surgery duration, less blood loss, shorter hospital stay, fewer positive margins, and 2-year recurrence-free survival in TORS was higher. So there's a trial there's a study known as RECUT study. So in this transoral robotic surgery for recurrent tumors was analyzed, and the most important point of this study was that the margin that was taken, the margins. If the margin was less than 1 millimeter, the 2-year local regional control was 54.2, and if the margin was more than 1 millimeter, the 2-year local regional control was 80.9. So generally we take a 1 centimeter margin. With this study, it was shown that even smaller margins could be taken and were acceptable. So is there any comparison of TORS with radiotherapy? Yes, there is. There is a Orator trial. The Orator trial, it compared transoral robotic surgery with the radiotherapy. So in this trial, patients with early T-stage squamous cell carcinoma, which met their inclusion criteria, they were taken and they were randomized into 2 arms, arm 1 and arm 2. Arm 1 included radiotherapy and chemotherapy, and arm 2 included TORS and neck dissection. The primary endpoint was quality of life index, which was MDADI score, and secondary endpoints were overall survival, progression-free survival, quality of life indexes, toxicity, and swallowing function. So the long-term results showed that TORS was comparable to radiotherapy, and the results, although they were slightly better in radiotherapy than TORS, however, these did not qualify as clinically meaningful. So there's another trial known as Orator 2 trial. This was for de-escalation of the oropharyngeal squamous cell carcinoma. In this, P16 positive squamous cell carcinoma patients were taken, and they were randomized into 2 arms, arm 1 and arm 2. In arm 1, radiotherapy with 60 gray was given with weekly cisplatin if multiple nodes were positive or if single node was more than 3 centimeter. And in arm 2, TORS with neck dissection was done. and adjuvant RT was given with 50 to 60 gray, and no chemo was given. The primary endpoint was 2-year overall survival. However, this trial was halted. Why? Because there were 2 fatalities in the surgical arm. One was the spinal abscess in 1 month after post-operative radiotherapy causing spinal cord compromise. And the second was a fatal hemorrhage in the base of the tongue excision. So this can be because of the 1 centimeter margin that was taken. So we have seen in the recut study that even lesser margins can be acceptable. So surgical approaches with de-escalated adjuvant therapy, current ongoing trials. So HPV positive oropharyngeal squamous cell carcinoma has traditionally been associated with surgically better outcomes. With the advent of minimal invasive surgical therapy, TORS and TLM, the goal is to spare or diminish the needs of the adjuvant treatment. So several prospective randomized surgical trials with de-escalated therapy are underway. So a few of them are ECOG 3311. So this is a trial with the stage 3 and 4 HPV positive oropharyngeal squamous cell carcinoma patients, and they are treated by transoral surgery and neck dissection. The aim of this de-intensification trial is to determine if similar outcomes can be achieved with a lower dose of post-operative radiotherapy. The PATHOS trial, which involves HPV positive cancer, T1, T3, and N0 to N2B cases. They are treated by transoral surgery and neck dissection. The aim of this trial is to identify patients in whom adjuvant treatment can be de-intensified after transoral surgery. Patients are stratified into 3 groups according to the pathological changes to receive either 50 or 60 gray of adjuvant radiotherapy with or without chemotherapy. Transoral head and neck surgery compared with radiotherapy, aortic, the best of trial, the best of the surgery and the best of the radiotherapy is being compared in this. And the primary endpoint of this trial is swallowing function. And the secondary endpoint is to compare overall survival between the 2 treatment methods. So take home messages: surgery, it can be used in upfront cases, in salvage cases, and it is a part of the treatment de-escalation programs. So I would like to share a video from our center by Dr. Saurabh Arora. So this is a video showing TORS being done in a salvage cases. This is a salvage case. This is a case of recurrent base of tongue tumor, which is approximately 2.5 centimeter. You can see that the resection is being done with monopolar cautery. And the TORS, it provides the clearer, wider view of the surgical field. I'll just pass forward this. Thank you.
नहीं 8 मिलीग्राम लिखा था मैंने खुद लिखा था नहीं 8 मिलीग्राम
Thank you, Dr. Ghatdeep. Please mute your mic. Mr. Abhilash, please mute your mic. Nidhi, please mute other people. Now, I would request a mentor of this session, Dr. Akshat Malik and Dr. Suman. Please ask some questions and guide her and take questions from the chat box. Dr. Mudit and Dr. Saurabh also can guide. Yeah, please.
Yeah. So I think there were already a couple of questions which were discussed out there in the chat box. One question was regarding the margins. So the slide which she had showed was regarding TORS, and many times we are happy with even lesser margins. If the surgeon is happy with the resection, then it's okay. But definitely, if you can get more margins, it's always welcome. And then ECOG 3311 is definitely published. Yeah, sir.
So Dr. Akshat, I think it's not in the per primum case, the 1-2 millimeter margins are there.
That is
we
in
can see
salvage
many
setting.
studies.
Yes,
salvage
that is
setting,
in salvage setting.
Still debatable. It is still debatable. Only one study has come till now, and it is still debatable to take 1 millimeter margin for the salvage setting. In all other studies, they have said even for the open surgery that even for the other subside, it has to be more than 5 millimeter margin. So we can't judge it on the one study to change our practice for 1 millimeter in the salvage.
Completely agree with that. But this is the evidence which is growing, and this is what we have right now. We of course don't have higher level evidence for this, nor are there more studies on that. But I believe she had highlighted this for the reason that, in orator 2 they were taking 1 centimeter margin, and like you also do TORs, and you can also understand that how rarely you will be actually reaching the cervical spine to cause cervical spine osteomyelitis out there. So we need to understand the anatomical constraints and take margins accordingly. There was another point in the chat box where we had mentioned that superior constrictor, if that is intact all around. So some people are also of the opinion that that will also be okay. But yes, definitely no high quality evidence exists for this, and people are still trying out and analyzing their results.
Yeah, but when you are saying, so this is high quality, and we are in the conferences, we can discuss these things. But for the students, I think there should always be the superior constrictor should be come out whenever they have to give the answer in the exams.
Yes, superior constrictor should come out, but thing is, even superior constrictor is just couple of millimeters. So I agree with you. If someone is asking, they should mention 5 millimeters should be there in final histopath.
Hello. Hello.
Yeah, please.
Yeah. Just want to clarify about that 1 centimeter margin in orator trial. Actually, Nichols was the person who had published this trial, and we had, because taking a 1 centimeter margin for TORS is very impractical. You can't do TORS if you take a 1 centimeter margin all around. So usually, we mailed him regarding what was the margin which he has taken in this trial. So pathologically, if it's more than 2 to 3 margin, that was considered negative in this trial. But I don't know why they have written 1 centimeter margin. But that's, you don't aim for 1 centimeter margin. If you take 1 centimeter margin, I don't think so. You will resect or you will require reconstruction most of the TORS patient. So it is not 1 centimeter margin, but definitely you should have, because most of the studies have told for HPV positive patients. We don't have much studies regarding HPV negative. Only recurrent studies showing that we can take few millimeter margin in HPV negative even. That's what I want to say regarding that orator trial. Yeah.
So Dr. Mudit, if it is a 3 millimeter margin in the patient, you have taken 5 millimeter, then it's shrunk to 3 millimeter. So at least you should aim for 5 millimeter. Then
yes, not 1 centimeter. I'm saying 1 centimeter.
Yeah, not 1 centimeter, but 1 millimeter is too less for the cases.
No, 1 millimeter you will never aim. It might come. Okay, you will aim for at least 5 mm, 6 mm margins. At least you will aim that. Your aim, as you told, should be there. But you will not jump in for adjuvant treatment because of that. That's what I'm saying.
Yeah.
So that is the important point which Dr. Mudit you have raised, that when adjuvant should be considered after, like if you are doing a per primum resection and there, if margin is coming this much, then when adjuvant therapy is to be considered. So this is again a controversial topic where people still don't have a consensus. Of course, the standard teaching is that should be more than 5 millimeter, but then there are several other studies where they have mentioned that, like even in the orator 2 study where you have mentioned that they were considering less than 3 millimeter as close margin. So this between 2 to 3 millimeter or 2 to 4 millimeter, it varies study to study. So we are still not sure when to consider adjuvant for these cases.
And most of the studies are HPV positive. ECOG trial, which was there, good trial, where they said 3 mm margin was taken, which is there. So it is where 2-3 mm margins. If you see NCCN also, they also say that your margins, if it's more, but they write a line there that
Great. Any other questions or remarks from the audience and the participants?
I will ask Dr. Sumant. Dr. Sumant, will you want to say anything?
Yeah. Just Ghatdeep?
Yes, sir.
Apart from your tumor selection criteria, is there anything else you will work up on the patient before you selecting a case for robotic surgery or any transferal approach?
Sir, we will see the ECOG status of the patient.
Okay. swallowing assessment. Okay, swallowing assessment, pulmonary function test. Okay, so these TOS cases, when you compare with this robotic trials, most of the criticism that comes to like a surgeon is like these cases are super selected cases because they are evaluated for swallowing evaluation also and the pulmonary function. So if a patient is a base of tongue having a poor pulmonary reserves, so patient may tend to aspirate during the post-op. So there are some like during surgery, I mean during your evaluation part, your functional assessment, especially the pulmonary function test and swallowing assessment, should be must. Second question: do you have any trials from in India where they have been evaluated this TOS with conventional approaches in HPV negative?
I don't know, sir.
There are two publications, like one is from the Bas group and the other one like published from AIMS, Dr. Alok Tikkas. So that is a match paired meta-analysis propensity match score analysis. So you should go through it before your exam. Okay, it's a two-arm trial that they compared this TOS group with the conventional arm. It's match paired. They evaluated, and in fact they found that because of the surgical approach, we tend to risk stratify the cases and into a high group and a low group. So the low group, they may we may avoid the chemotherapy, and in high risk groups we can go with the CPR. So there's a good publication you should go and look.
So thank you, Dr. Suman. So what I could understand, single modality treatment is good. We should try for single modality treatment. Am I right, Dr. Ghatdeep?
Yes, ma'am.
Single modality treatment is good enough. Na? TORS you are doing in early cases.
Yes.
T1, T2.
Yes, ma'am.
But we should try to have single modality treatment.
In early cases, yes, ma'am.
So it should not happen. We are doing anything. We should try. We are doing TORS, then something is positive, then we are doing radiotherapy. So I think anyone want to comment, then we will proceed towards another lecture. Dr.
Yeah, very rightly said, ma'am.